Good morning. Let's have a listen to that fantastic source of health information, ABC Radio, and the amazing knowledge bastion of all things, Dr. Norman Swan, ABC health reporter. His guest on this episode is Professor Lorimer Moseley, who's a pain researcher and professor of physiotherapy.
Let's get back to pain, and in one of the commonest locations, low back pain. How long does it last after it starts, and with how much disability? Doctors and physios have been reassuring people with low back pain for years now not to lie down, avoid opioid painkillers, and in general keep moving and you'll eventually be fine. Is that true though?
Well, before you go on, I just want to chime in because we use low back pain as a term all the time, but what do you actually mean?
Well, for this particular study, this review, it was pain in the low back, in other words, below the chest and above the buttocks, which may or may not go down into your legs.
Okay, just hold it there, Norman. Anyone who complains significantly of back pain with significant pain radiating down into their lower limbs, that must be treated as a red flag and should be passed on to a specialist spinal or neurosurgeon. Do not ignore that symptom.
Now, a group of Australian researchers has brought together the evidence from around the world on acute low back pain, less than acute low back pain, and persistent low back pain to see what people experience and for how long. The senior author was Professor Lorimer Moseley of the University of South Australia. Welcome back to the Health Report, Lorimer.
G'day, Norman. Thanks for having me.
The first thing I'd say looking at your review is that the quality of the studies you looked at was pretty crap all round. So I'm not sure how you can draw any conclusions.
Well, I think that's quite harsh, to be honest. I think we certainly were disappointed with the quality and number of studies on the chronic back pain group. And that's the group that we call it persistent or chronic. They're people who enter the studies. Yeah, where they've already had back pain for more than 3 months.
Well, this is unfortunate because the study didn't have good information regarding chronic back pain. It had reasonable information about acute and subacute, but not chronic. And guess what? Chronic back pain is the biggest problem that we're facing, one of the leading burdens of disease on the planet.
But there's a bigger body of evidence, and I completely agree that some of the primary studies are crap, and we do suffer a little bit from that sort of rubbish in, rubbish out problem that you can get with meta-analyses. But there's 20,000 patients represented and pretty good follow-ups for that acute and subacute stage. So I think we can be really confident that if someone says to you in that amount of time, up to 6 weeks, you've got back pain, well, there's a good chance that your back pain will recover.
Okay, well, let's get to the numbers from the study. So if you've got acute back pain, your back's thrown out, you're really sore, and 6 weeks after the pain started, how long on average is it going to last? And how many people slip through to the next stage?
Yeah, great way of thinking about it. I think we can more easily answer the second one, so that we've got about 70% of people recovering in that next 6 weeks.
Okay, so let's just digest what he's saying there. If you have an episode of acute back pain, 60 to 70% of people recover within 6 weeks. Okay, so that means 4 out of 10 people don't recover. And that's pretty significant. 3 to 4 out of 10 people don't recover within 6 weeks if they have an episode of acute back pain. And the researchers just seem to gloss over the fact that 3 to 4 out of 10 people do not recover after 6 weeks. Let's see what else he's got to say.
You've got acute back pain. You don't know you put something out. I always try and jump on that assumption. You've got back pain.
It just comes on.
And we've got to get rid of the idea of things being wrecked, because most back pain, nothing is wrecked in your back.
And there's no one event.
Yeah, exactly. And then I guess if you do slip through the cracks for past that first milestone of 6 weeks, then we've got about 70% of those people are going to recover.
And that's what you call subacute back pain. So it's gone down a notch.
Yeah.
Okay, so Norman's now putting subacute back pain, the ones that haven't recovered, into a less significant category, and by saying it's gone down a notch. Well, in fact, the severity has gone up a notch. These people are now getting closer and closer to chronic back pain, which is a severe disabling condition. And what Lorimer is saying is that if you reached the subacute phase, again, there's 70% of recovery within another 6 weeks. And that means 3 people out of 10 do not recover from their subacute status. So that means that those 3 people are going on to persistent low back pain and chronicity. So now we are reaching a very severe state with a condition of severe pain and disability in 3 out of 10 people. And yet the impression is that we should all be, fairly casual about back pain, when 3 out of 10 people in the subacute phase do not recover.
Yeah. So the fact that it's still there does elevate your risk of it not recovering as quickly as you'd like. But when it's still hanging around at more than 3 months, that's when the data that are available, and as you said, they're not perfect at that level at all, but they do agree with the general perception out there with all the other data we've got, that once you've got chronic back pain, it tends to hang around. You tend to have it for a lot longer, and recovery rates are much lower once it's been around for that sort of more than 3 months.
Okay, so let me break that down for you. In the acute phase, where they're saying, nothing's broken, nothing's damaged, you're not going to fall apart, stay calm. That acute phase, 3 to 4 out of 10 people don't recover. They progress on to the subacute phase, and then once you get into the subacute phase, he said that 3 out of 10 of those people don't recover either, and then they go on to chronicity. So that really means that 6 or 7 out of 20 people who start off getting acute back pain progress to this condition that is almost like a different disease altogether, which we will call chronic low back pain or persistent low back pain. 6 or 7 people out of 20 progress to this horrible state of chronic back pain. And the message that the researchers are trying to put out into the public is, hey, if you get low back pain, it's no big deal. Most of you get better within 6 weeks. Yet they are leaving out the converse argument that if you get low back pain, then there's a 6 or 7 out of 20 chance that you are going to progress to chronic low back pain. Why is that not being spoken of? Why are they downplaying the fact that if you get an episode of acute low back pain, that is a warning sign that you are expressing some very poor biomechanics that are driving your likelihood to progress to chronicity? That is the main message that we should be getting out into the public, not downplaying the insignificance of acute low back pain. It is a very significant sign.
With Christina Abdel-Shahid a little while ago on the Health Report, we used some big words, nociceptive and neuropathic pain. So neuropathic pain is where the original cause has gone. There's nothing left that's physical. It's real pain, but it's very hard to define why you're getting it. And then there's nociceptive pain, which is where, presumably at the beginning of the process, you actually have done, your back has degenerated or whatever, and you've got actually a physical cause. So when you've got persistent pain, is this neuropathic pain where the back is healed, but you've got pain and we just don't know why?
Not really, no. So
Okay, Norman's getting himself all mixed up here. He probably needs to go back to medical school and read some basic textbooks about the musculoskeletal system and back pain. You can divide pain into nociceptive and inflammatory. You can then add on neuropathic if a neural structure is injured, and then you can add on the central sensitization element, which is what happens in chronic pain. and that is when the nervous system becomes sensitized to pain, so it acts in a maladaptive way and amplifies pain that would otherwise be experienced. So that's central sensitization, and they've come up with a new name for that. Not that it makes any difference at all. I still don't understand how to manage it well. And Norman is getting his wires all crossed there.
We now categorise pains as three versions, actually. So nociceptive.
God, I'm going to have to go back and talk to Christina again. Right, okay.
In fact, you really don't have to worry too much about that. Like most acute back pain will be associated with some degree of maybe inflammation. Now, there's a lot of acute back pains that take care of themselves. We don't know why they started, and we don't know why they started, and we don't know why they started, and we don't know why they started.
The absolute biggest mistake that Lorimer has conveyed in this interview. We don't know why they started. He'll go on and talk about inflammation and nociception. And yes, we do know why they started. The spinal joints are joints, and the most significant thing that determines whether they are healthy are the biomechanics associated with that joint. That is why they started. That is why 3 to 4 out of people do not recover from their back pain and go on to subacute pain. And then another 3 out of 10 do not recover from their subacute pain, and then they go on to chronic, disabling, persistent back pain. So we do know why they started. Fix the biomechanics and you fix the whole problem of low back pain. So Professor of Pain Science Research and Physiotherapy has just said we don't know why they started. And this is the biggest mistake in the back pain therapeutic industry, thinking that there is no cause for an epidemic condition. An epidemic and ubiquitous condition, by definition, must have a common, simple cause. And we do know why they start. It's poor biomechanics, which leads to poor joint stability, and then pain as a consequence of micro instability. And you can hurt your back lifting up your mobile phone from a coffee table. It doesn't have to be doing something super heavy. It's because of poor biomechanics and micro instability. Okay, listen to the rest of this. All the best.
That may not even be associated with what we're describing as nociception. And nociception is a really unfamiliar word. All it means, if people think about noxious chemicals.
There's pathology there.
Chemicals, danger. Well, there may not be pathology, but there is activation of danger detectors that are in the tissues, right? So we activate danger detectors often through the course of our normal daily life, and that's what keeps us safe. And acute back pain is thought to be really appropriate to keep us safe during that little threat.
Yeah, that's exactly right. The noxious chemicals, or the nociceptive pain and the inflammation that occurs as a consequence of biomechanical stress, which then drives biological processes, nociception and inflammation, that is painful. It's no different to pulling a hair follicle, pulling your hair, and it causing pain because it sends a message to your brain to say, stop doing that. That's biomechanical stress on your joints. And if you keep it going, it then converts into biological inflammation. And we know what that feels like. That's like sunburn. Inflammation is uncomfortable.
The next category that you talked about is neuropathic. That's when you can demonstrate an injury or disease within your nervous system. And that requires tests, particular nerve tests, or a diagnosis like diabetic neuropathy or or multiple sclerosis or a brain injury. The third category, and I think that's more what we're talking about with chronic pain, they're calling it nociplastic. And we've done surveys with hundreds of consumers and said, what do you think we should call this? Because that name is stupid. And they come up with what we now use, and that is pain system hypersensitivity. And you're right. What it acknowledges is that pain is, unfortunately, it's messy and complex, and there's many factors that contribute to pain system hypersensitivity. And chronic back pain fits into that category 99.9%. of the time. And
So
the
what
approach that we have to take
Sorry, go on.
is not about a single pathology, because that's not the problem. We have to take a broader approach to the problem.
So just briefly and finally, can you predict then who gets to what place in that route, in that pathway to persistent pain or not? Is it physical situation? Is it how your GP treated you? Is it what your GP told you? Because there's some research saying, look, if the GP is really negative about it and says, you know, this is really bad, you've got to lie down to it and blah, 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 you actually are more likely to end up with persistent pain than not. I mean, what are the key factors that people need to take into account here?
Yeah, well, the key factors are not the ones that you expect, right? So the key factors are not the type of injury or even the extent of the injury. But in answer to your question, no, we can't reliably predict who's going to recover quickly and who's not. But we do know things that change your likelihood, and they are things like you've mentioned. How worried are you about this? What else is going on in your life at that time? What other threats? How healthy are you? How are you sleeping?
Well, yeah. People who have reached the chronic stage of back pain not sleeping well, Lorimer, and they are very worried about their condition. They're worried about their relationships. They're worried about their finances. It does create a whole heap of stress and anxiety and depression symptoms. That is not the reason why these people are in trouble in the first place. The reason that you're forgetting to mention that they're in this problem in the first place is that you've done so poorly with managing the acute and subacute stages of their pain. The 3 out of 10 people that fail to recover after acute back pain, and the 3 out of 10 people that fail to recover after subacute back pain, that's 6 out of 20 people that then go on to persistence. And then you're trying to say it's not the reasons that you expect, and that the way to help these people to recover is to deliver cognitive, functional, and cognitive behavioural therapy approaches. No, that is an absolute failure, and the real solution is to stop people from becoming chronic in the first place.
And we have to think really, really broadly about it. I guess the key point from this study is that there are treatments that train the brain and body, the pain system hypersensitivity and the body, and those treatments are the best treatments we have. So it's not like we don't have interventions that work. We're just not getting them to these people with chronic back pain. And that's, I think, where the attention has to go.
We're running out of time, but very briefly, what are those treatments?
Well, there's a range of treatments, but they all have in one thing in common, and that is they spend a lot of time shifting your understanding of what the problem of back pain actually is, away from diagnosis like a slip disc or arthritis or degeneration, these sort of things, because that's not the cause, towards understanding that there are many factors that influence pain, and the mix of factors will be different for each person. The consistent bits are movement, understanding the problem, and individualised self-mastery. You need a good coach to help you do it.
Lorimer, thank you.
Thanks for having me, Norman.
Lorimer Moseley, who is Professor of Clinical Neuroscience and Physiotherapy at the University of South Australia.